Before starting, kindly unmute yourself.
Good evening, everybody. Today's session, we have 3 cases. Welcome to all. And Dr. Bharat Kandari is also here with us to contribute to the session. And the first case, out of these 3 cases, we will try to finish over the next 1.5 hours. And each case may go for 15 minutes, followed by 15 minutes of discussion. And 3 cases altogether. The first case is by Dr. Sharath from Toronto, and he's presenting on a case of atrial cardiomyopathy.
No, just a minute, Narayan.
Yeah.
Can you speak a little louder, please, or come?
Okay.
At least for me, in Bangalore, it looks a little, sounding a little distant.
Yeah, I am moderating.
No. I'm also moderating. Sorry. I hope you can hear me. So we all have to hear.
Moderating my voice.
Yeah.
Anyway, speaker is Dr. Sharath. Probably
yeah.
he can.
Please, let's
Sure.
move on. Wonderful.
Okay. Should I start sharing my screen?
Yes,
please.
Yes,
Sharath, please go ahead.
Thank you. So,
Dr. Sharath,
yes.
can I ask you to just give yourself a couple of minutes of your own introduction, please? You don't mind?
Yeah, sure. I had my cardiology training at AIMS. Basically, I'm from Karnataka, but I had my cardiology training at AIMS. Baratte, sir.
Wonderful.
I trained initially in Chennai and then Madras Medical College and then in AIMS. I was in Australia before, and I had.
Where were you in Australia, Dr. Sharath?
Adelaide, sir.
Adelaide. With Prash?
Yeah.
He was wonderful.
Yeah, I know. He tells about you. From Adelaide, then I had moved back to India for almost a year. And at that time, this work was done with Dr. Narasimhan, who is my mentor.
Wonderful.
Now I'm in Toronto since 2018. So
fantastic.
That's
a very good introduction. Please go ahead.
Thank you, sir. Yeah. Can you see my screen?
Yes,
everyone?
Yes, absolutely.
Okay. So I thank the IHRS for this opportunity. I'm getting this opportunity to present in front of people who have learned a lot from all of you. So what I'm going to present is this paper, which was for a platform presentation on HRS, and also was a young investigator poster in the Cardiac Electrophysiology Society at the HRS. So unfortunately, we could not present it there. So we thank the IHRS for this opportunity. So I'm going to present a series of patients on granulomatous atrial cardiomyopathy presenting as atrial arrhythmias and lymphadenopathy. I thank all my colleagues who have helped me in this. So basically, atrial fibrillation is believed to be due to a conglomeration of risk factors. That's hypertension, diabetes, obesity, and so on. Traditionally, these risk factors are believed to cause or play an important role in atrial fibrillation. But there is a group of atrial fibrillation which may not have these risk factors or may present in younger individuals. The atrial myocarditis being a cause of atrial fibrillation in this setup has been very infrequently recognized. So we tried to evaluate the role of atrial myocarditis in atrial fibrillation in young individuals. These two are probably the earliest papers on atrial myocarditis. You can see these are patients who were rheumatic heart disease, and they underwent valve surgery for rheumatic valve disease, presumed rheumatic valve disease, and they found evidence of inflammation and giant cell myocarditis. If you see the second author, he mentions that even though they resemble rheumatic heart disease, they found that, I mean, if you read the discussion part, he says why it is not rheumatic heart disease, and it's more of a persistent myocarditis. So these two are probably the earliest works which suggest that atrial myocarditis by itself, isolated, could be an entity by itself in 1964. So coming to more recent times, this is probably a seminal work in 1997, Frustacci. What they did was they took up 12 patients with lone atrial fibrillation, and who had they say like they never had any of the risk factors as such, and they even did EP studies in some of them. They found no evidence of any pathology, but they performed endomyocardial biopsies in them from the atria, and they found evidence of atrial inflammation in 66% of them. And in the remaining, they had some non-specific changes and patchy fibrosis. So this 66% probably is the amount of atrial myocarditis in patients with so-called presumed lone atrial fibrillation. This is a very important paper which came out in '97. Again, Basso from Italy looked at the role of atrial inflammation in patients who had sudden cardiac death with WPW syndrome, like pre-excitation patients who died acutely. They found evidence of atrial inflammation, and they thought that atrial myocarditis could be one of the precipitants of fast atrial fibrillation and could be a trigger for sudden cardiac death in them. This is another important paper which came. By far, one of the largest papers comes from the Mayo Clinic series. This is like 2013. This is a retrospective analysis. Many of them, again, had presumed rheumatic heart disease as the diagnosis. And they looked up, they have reported about 13 patients with isolated giant cell atrial myocarditis. And these three papers give us a suggestion that myocarditis, which is isolated to the atria, is a really valid clinical entity. So coming to what we did, so on these lines, we try to evaluate patients for atrial myocarditis. Like we took 45 patients presenting to the outpatients at that time, and they had refractory atrial arrhythmias. And importantly, we tried to rule out all conventional risk factors for atrial fibrillation, like hypertension, diabetes, obesity, so on. We tried to rule out all of them, and we were left with 24 patients who did not have conventional risk factors, but had refractory atrial arrhythmias. And after evaluation, we found 12 patients with evidence of atrial myocarditis. This paper describes these 12 patients with atrial myocarditis. We have added 5 more after this, but at that time, we had 12 patients, which we are going to present now. What did we do? We did the usual labs, the CBC, the inflammatory parameters, thyroid function, echo. Some of them even had like exercise stress test. About 5 of them had an angiogram, which was like normal. Cardiac MRI was performed not to look for atrial changes. Predominantly, we try to look for anything in the myocardium, but no pathology was found in the MRI. And the most important part of the evaluation was PET to look for inflammation, and then we looked for the etiology of inflammation by endomyocardial biopsy or evidence of tuberculosis on them. So the most important part was to look for PET and look for evidence of etiology of the granuloma. So we tried to diagnose sarcoidosis by the standard expert consensus. Rheumatic heart disease was ruled out by the Jones and the WHO criteria. None of the patients had fulfilled the rheumatic heart disease criteria. And of course, we look for diagnosis of tuberculosis by AFB, PCR, and we also look for evidence of sarcoid and tuberculosis together, an entity called tuberculosarcoid, by finding evidence of both together. So these were our diagnostic criteria. Coming to the clinical features, like the mean age of the patients were about 47 was the mean age, predominantly male, about 67%. Important to note, 5 of them had stroke, about 41% of them had stroke. We have followed them up till about a few months back. And the mean LVEF was in the low normal range. Left atrial size was normal. We could not find much on the echo in these individuals. There was evidence of lymphadenopathy in most of them by clinical examination or by PET. We had evidence of sarcoidosis in, patients fulfilling the sarcoid criteria in 9 of them, and in the remaining 3, we had evidence of both sarcoid and tuberculosis. Standard antiarrhythmic medications were used in all of them, important to note that the CHADS VASC was lowish, like it was just around 1.1. So coming to the index patient, this patient led us to this evaluation. A patient from Bangladesh who had recurrent supraventricular tachycardia. He had AV and RT ablations there in the past. Came for a flutter ablation. He had multiple arrhythmias. 2 ablations, which I wouldn't say failed, maybe they recurred, but in a different form, like having both AV and RTs and flutters and fibs in the same individual, very young individual, not much valve disease. We did a PET CT, and one can find evidence of atrial inflammation. It's pretty evident from the PET, which we can see here, predominantly in the right atrium. Histopathology here shows evidence of lymphocytic infiltrate with granulomatous changes. What we did was to treat him with inflammation, thinking it's almost like the same principle which we used for ventricular myocarditis, like my senior Ajit had that as ventricular myocarditis paper, and later on Sachin has also described the value of treating inflammation in the ventricular myocardium. We try to go along similar lines, try to treat it by immunosuppression, and we can see the suppression of complete clearance of inflammation in him. No arrhythmias have recurred at this point. This was the index patient which led us into this direction of evaluation. Another patient, about 54 years, shortness of breath, presented with tachycardiomyopathy and stroke. Importantly, presented with stroke. We can again see evidence of atrial myocarditis, predominantly in the atria and very minimum on the septum. And again, this patient showed evidence of myocarditis on biopsy. So and again, treatment with immunosuppression, you can see the pre-treatment on the left and the excellent resolution of treatment.
Hello, can I interrupt you for a minute, please?
Yes.
Did you biopsy the atrium?
Yes.
So that means you allowed a patient with atrial flutter to undergo an open biopsy or a closed biopsy?
It wasn't an open biopsy.
Then how can you biopsy an atrium? You will bloody perforate the atrium, right?
No,
it's a typical atrial flutter. Dr. Sharath, please believe me.
Sorry,
can you go back on that slide, please?
Yes.
Yeah, go back. That's a typical atrial flutter.
Yeah.
Isn't it? I mean,
yes.
Any electrophysiologist who can eyeball that will see that.
Yeah, he had an ablation.
No, but that's besides the point. A lot of patients undergo ablation, but have you really taken an open?
No.
You just mentioned that he had a biopsy.
No. This patient had a lymph node which was biopsied. Not everyone.
That's okay. That you didn't mention it.
No.
Does the lymph node biopsy tell you that this flutter is because of sarcoidosis?
Should we allow him?
Basically, we are trying to diagnose
No,
sarcoidosis.
no. I'm just asking a question as a science.
Yeah.
I'm just asking.
Yeah.
Dr.
No,
JP, maybe we should let the speaker
probably
finish and
No,
then we can discuss
I'm
that.
just asking because this has to be science. So sorry. Okay, let's go on.
Yeah, we can probably finish the presentation and then go for questions. No, sir. Probably he may have
Dr.
some
Narayan probably also,
explaining.
I don't know.
Yeah.
Because I'll present something about the biopsies, which you have not mentioned, about my paper on rheumatic heart disease.
Sure, sir. We will do that.
JCE has presented, presented biopsies. Okay. Bye,
Okay.
please. Thanks.
Sir, please go ahead. Yeah, we will discuss these things.
okay. So, so we can see excellent resolution of inflammation pre-treatment and after therapy here with the steroids and methotrexate. So this is the second one. He had a significant improvement in ejection fraction and parameters in the echocardiographic parameters. So this is another example. The first one, young patient presenting with refractory atrial arrhythmias, and the second one here presenting predominantly has a tachycardiomyopathy. The third one here, another example, 48-year-old patient, again, LV dysfunction, presenting with atrial fibrillation predominantly, and had atrial inflammation. To note, this patient also had some ventricular inflammation too. Again, treatment, this patient had a device also, and following immunosuppression, we can see resolution of inflammation in the atria, and also in, there was persistence of ventricular inflammation here, which went away and he became clinically normal. So these are the various presentations which we would like to highlight. So coming to the presentations, predominantly about 50% of them had flutter. AF was present in all of them. In the other arrhythmias were flutter and AVNRT. Dyspnea, chest discomfort were common symptoms along with palpitations. And importantly, about 42% of them presented with stroke. Cardioversion had to be performed in 75% of these individuals, and at follow-up, only 25% of them had recurrent AF episodes. Coming to the PET, most of the uptake was present in the atria, and biatrial uptake was present in 41% of the patients, and only 4 of them had LV uptake. So predominantly, most of the patients had isolated atrial uptake. The MRI, just one patient showed some evidence of delayed enhancement in the basal septal region, but otherwise was pretty not so remarkable in everyone. Histopathology, lymph node biopsy was performed. We had like clinical lymphadenopathy. Some of them had biopsy from the right atrial part of the septum and on the ventricles. And then coming to lymph node biopsy was performed in a majority of them. 94% showed evidence of granulomatous inflammation. One of them showed predominantly lymphocytic infiltrate. Granulomatous inflammation in 75%, and caseation was found in 3 of the patients. They were probably the tuberculosis group. I mean, they were the tuberculosis group. Tuberculosis testing was positive in 66% and by PCR or by DNA or by culture in one of the patients. No patient had evidence of pulmonary tuberculosis, and final diagnosis by the consensus criteria was sarcoidosis in 75% and tuberculosis in 25%. Coming to ablation, the flutters were ablated, the AVNRT was ablated, cardioversions were successful in all. Because we saw that majority of the patients had a stroke. I wouldn't say majority, but 41% of them had a good sizable population had stroke. So anticoagulation was prescribed for all patients. And standard antiarrhythmic therapy was given for most of them. Coming to disease-specific therapy, steroids used in 41% with methotrexate in 2 of them, and corticosteroids and tuberculosis therapy in about 4 of them based on the diagnosis. So we would like to, give a flow chart for the management of atrial fibrillation without established risk factors. First is to rule out systemic causes for the same. Then we look for inflammation by PET-CT. We find evidence of atrial inflammation. Then we try to demonstrate the granuloma by a biopsy, either from the myocardium or from the lymph node. Once we find that, we look for evidence of what is the cause of granuloma in this patient. Then based on the etiology, you would treat by either immunosuppression or anti-tuberculosis therapy. Of course, oral anticoagulation and anti-arrhythmic therapy would be prescribed in all. Inflammatory markers showing significant reduction in inflammatory markers at follow-up, and improvement in ejection fraction also was noted at follow-up, along with a significant improvement in NYHA class. So what are the possible consequences of atrial myocarditis? Acute myocarditis presenting with lymphadenopathy and atrial arrhythmias is something which we are trying to describe now. The other things which can be caused by this are WPW, could be sudden cardiac death or precipitating atrial fibrillation in WPW has been described. It could present as just stroke without AFib2. And it could provoke atrial arrhythmias, and importantly, it could be a cause of bradyarrhythmias and standstill. Chronic atrial myocarditis could be, again, a substrate for atrial fibrillation, could cause stroke, and could be the cause of long-term conduction system disease at follow-up. We need more follow-up to know this. And most importantly, we observe patients with unexplained scars on without prior surgery and ablation. And this could be one of better explanations for the scar which we observe in the atria, which could cause flutter at follow-up. Is there an isolated arrhythmogenic atrial myocarditis? This again has been answered, like just 2 patients, but a very important thought which has been presented in the European Heart Journal way back, where they showed fractionation. We can see fractionation in the atria in the lead called MRA, and we can see normal voltages in the HRA. And one can find evidence of inflammation in myocardial biopsy in these patients. So this is probably a very valid entity which has been described but hasn't been evaluated thoroughly. What could be the pathogenesis? Why does myocarditis predominantly limits itself to the atria? Atria-specific autoantigens could be causative. Gene expression is known to be different in the atria and the ventricular myocytes. And there could be differences between these two. It's been well known, like transcription factors are different, and structural proteins such as myosin light chain is different. And ion channels, like drugs like vernacalant, which is known to act predominantly on the atrial myocardium, shows us that the ion channels may be different in the atria and the ventricles. So there could be autoantibodies which could target these, which are more atria specific. These are just thoughts. Arrhythmogenesis in myocarditis, why does it resolve? We know that the acute phase of myocarditis causes inflammation. Because of viral persistence in the cell, this can cause ion channel remodeling. This is being described in animal models. And myocardial edema, typically like a Takotsubo, where myocardial edema goes away and we don't have much risk at follow-up. These could be potential explanations for the inflammation which occurs in the acute setting, and it goes away probably over a long time. Persistence of virus or the persistence of autoimmunity could be the cause of long-term damage and future arrhythmias. The lessons actually, this answers your question. This is an editorial which was written up for the paper by Frustacci in the circulation. Basso and Thiele, very important workers, they have clearly mentioned that the atrial specimens need to be evaluated. And even Frustacci study, they did atrial biopsies from at least 2 or 3 areas in the atria. And these authors generally believe that the atrial myocarditis is missed as a cause, and we may think it's lone atrial myocarditis. So atrial biopsies need to be done, is been well described by these authors. Limitations, well, we didn't look at anti-atrial antibodies. Of course, we didn't have the facilities probably, and we didn't look at viral titers in this, probably we need longer follow-up in these patients to look for what does happen. Does it translate into a scar at follow-up? We need longer follow-up. The evaluation, once we establish a granuloma, we have to look for an etiology of the granuloma, which may be different in different areas, like Chagas or something may be the cause of myocarditis in some other geography, whereas in India, it's already established in ventricular tachycardia papers that sarcoid or tuberculosis is a cause. We need larger databases are needed to accumulate more data in this regard. So coming to more conclusions, atrial myocarditis can be a presentation of sarcoidosis or tuberculosis isolated. The presentations could be refractory, recurrent, and multiple atrial arrhythmias. Atrial tachycardiomyopathy could be the next important presentation, importantly in a young individual. Echo may be showing pretty much not much of dilatation, but it could be early stages. I mean, when I say dilatation, I mean in the atria. And they could present as stroke because at least 41.6% of our patients had stroke. They lack the traditional risk factors, and we assume it to be low atrial fibrillation. They have excellent response to immunosuppressants. And we could see that at this point, like even with the significant follow-up, we haven't been able to see recurrences. Maybe long-term, we may be able to see it. So I conclude by saying atrial arrhythmias with granulomatous lymphadenopathy and inflammation could be a presenting feature which is unrecognized, should be suspected in young individuals with atrial arrhythmias and stroke without conventional risk factors. Thank you.
Thank you, everybody. Can you hear me?
Yeah.
Wonderful. Fantastic presentation.
Thank you.
We have a number of people, including Narasimhan, on this thing, including the EP team from AIG. Now, can we get some, inputs from Dr. Narayan Nambudri? I can only see his head.
Yeah.
And now I can see him better.
Yeah, interesting case, Sharath. Very good case. I mean,
and Dr. Bharat, I can only see his head. There is a bright light behind him.
Dr. JP, I think let Dr. Namudri finish. He was saying something.
Yeah, please.
Dr. Henan, please go ahead.
Interesting observations, Sharath, well presented.
Thank you.
My query is that when you don't have a clear evidence of direct involvement of atrial inflammation, because in most of the cases, and 5 of them had endomyocardial biopsy, you told none of them was from atria. And why do you call them as atrial myopathy? Because atrial inflammation, you have only indirect evidence. And granulomatous myocarditis, you have indirect evidence in form of lymphadenopathy and MRI involvement of the ventricles. And most of them, as I could see. So when you get an atrial myopathy, just I will go
Narayan.
Yeah.
So
when you,
we'll restrict it very quickly.
Fine.
To about 4 or 5 questions because I see a lot of questions.
So
we'll summarize it as this thing. So let's invite something. Now the first thing is, are we thinking of myocarditis which is an inflammation, or a cardiomyopathy. The first definition has to be completely different. Okay. So is it a myocarditis? Myocarditis, pericarditis are inflammations. And if you see, there is a beautiful, this thing, you know, thing from, you know, the thing from AHRS, APHRS about cardiomyopathies. Cardiomyopathies are not completely true than myocarditis. You know, myocarditis are different. They are inflammation. The first definition of cardiomyopathy was done in 1972 by, I don't know who, but Zipes described this in 1997 as a myocarditis. So this is not cardiomyopathy, my friend. Please.
No, we are saying it's myocarditis.
No, it is myocarditis. So
there
is a difference between myocarditis versus cardiomyopathy. So we have to define. And when you look at, no, I am taking a long time because I see a lot of questions on this.
Yeah, we can.
When we see inflammation, it's different. When you see myocardial, you know, cardiomyopathy, it's different.
Yeah.
Right? Inflammation is different than myocarditis. Right?
Sarath, you want to explain?
Correct. Okay. May I intervene here, please?
Yes,
I think we have Dr. Narasimhan also on the online with us. And Dr. Narasimhan, I would request you to kindly comment, please. Dr. Narasimhan. Sir?
Yeah.
Yes.
Yeah. See, the thing is, we need a practical framework. I agree what Dr. JP and Nambudri was saying. It's a difficult thing. For example...
No, Narasimhan, please believe me. We can't mix myocarditis with cardiomyopathy.
So that is what he's trying to explain.
Cardiomyopathy has got a different this thing. We accept that sarcoidosis can give rise to atrial myocarditis.
Yeah,
but we can't mix atrial myocarditis with cardiomyopathy, please.
Yeah, Dr. JP, finish, please.
I hope. Now we accept that there can be very rare causes of, you know, myocarditis causing all myocarditis, pericarditis give rise to atrial fibrillation, please.
Narasimhan sir, probably you can comment on that.
So, if I may, the Vanita, thanks. The valid concerns, I think I fully agree with whatever JP and Nambudri are saying. The first description is you go to herpes simplex encephalitis. We don't biopsy the brain to make a diagnosis of encephalitis, but it's from patient's point of view, it's an important diagnosis. It's life-saving.
No, we don't biopsy.
So,
Dr. Narasimhan, please. There are conditions which have been described, and APHRS, HRS have already described this. What should be described as myocarditis? Please don't, you know, we can't describe the brain versus this thing, please. I am very sorry about this. I accept that you're a very senior, but nevertheless, we have to stick to something, right?
Let me complete, no, sir.
No. I'm not able to accept this concern.
Yeah.
Okay.
Yes, sir. We have to move forward, please.
No. We
so
have to
as Dr.
I can't accept this. No. I can't accept this inflammation versus this thing. We can't confuse the brain versus. I've got the myocardial biopsy. I have presented this. Okay, please. Sorry. The myocarditis is different than cardiomyopathies. There is already been a very big paper from APHRS, HRS. Zipes has described this in 1997. Before that, cardiomyopathy has been described in 1972. So cardiomyopathy is different than myocarditis, my friend. So we can't put this wrong notion on things. No, this is not science.
That point is well taken. We discussed that. No, sir. Let us
No. So Could we please move on? Is something from Paul Choco? Any nuclear study for inflammation like gallium-67?
No.
Then
No.
there is Ramdev Yadav. We have to move on. I don't think, see, we can't mix, we can't, Dr. Sharath, I accept your fantastic presentation. But nevertheless, we can't mix myocarditis with cardiomyopathies.
I agree. But
okay, so please, yeah. No, it's a good presentation, but that's about it. That's how I accept it. I don't know what Bharat Kantaria says. Risk of perforation on atrial biopsy. Where did you take the atrial biopsy? Was concerned by Ramdev.
Biopsies are taken from the septum.
How many? So let me tell you. Let me tell you. We have done this mitral stenosis. JC 2018. Please see that. Can't accept. Please. Let's go. Next, please. Hello.
Yeah.
Great presentation, but nevertheless, we have to distinguish between myocarditis versus cardiomyopathy.
I mean, basically what we are trying to say, it is myocarditis.
Do you want every single patient with atrial fibrillation to undergo a biopsy?
No.
Do you want every patient to undergo steroid therapy or methotrexate?
You're not talking about every patient. There is that
then is this actually cardiomyopathy or myocarditis?
It is myocarditis. There's no doubt. There's no doubt it's myocarditis, and over the long term,
myocarditis requires this thing, whether it is sarcoid, non-granulomatous, or granulomatous, it's okay.
Yeah, I think we should move on to the next.
Yeah, wonderful. Let's
already spent 40 minutes. And
so I can't sort of stop. Now I see Narayan very active. Wonderful.
I think probably we'll go to the next case by Dr. Vikram. And
good evening, everyone. Am I audible?
Yeah, wonderful.
Dr.
We have been waiting for a long time, Dr. Vikram.
Dr. Dheeraj, please mute everyone.
Dheeraj, please put everybody on mute, and only speaker can unmute themselves, please.
Yes, good evening, everyone. So I'll be presenting an unusual case of an electrical storm. So this is a case of 17-year-old male who was treated elsewhere for recurrent episodes of generalized tonic-clonic seizures. He was admitted in a peripheral setup as a case of status epilepticus, for which he was started on injection phenytoin. What the treating physician noted was after starting injection phenytoin, the status epilepticus worsened, and during one of the episodes, what they noted was a ventricular fibrillation, and the patient went in for cardiac arrest. And at that time, they had resuscitated the patient, and with that, they have started, along with injection phenytoin, they had given injection lignocaine, injection amiodarone, and they referred to us as a case of survivor of sudden cardiac death. There were no significant comorbidities in this patient. There were no significant past medical history, no family history of any SCD or any seizures. So this was the first ECG taken in our emergency. So this is an apparently normal ECG, and the corrected QT interval was around 460 millisecond. So when we reviewed his ECG taken in outside setup, what we noted was V1 to V3 showing V1 and V2 showing a type 1 Brugada pattern. So as we made the diagnosis in our emergency, patient went in for a florid VF storm. So he initially had a polymorphic VT, then he went in for atrial fibrillation, but the predominant rhythm most of the times that we cardioverted were ventricular fibrillation. So you can see that in the upper ECG, patient also had a recurrent ventricular ectopic, and some of these ventricular ectopics were also triggering a ventricular fibrillation. Patient also had a monomorphic VT. So with this, we diagnosed the patient is a case of Brugada and Brugada VF Strom. So we stopped phenytoin, which is a sodium channel blocker, and we also stopped amiodarone and lidocaine. We started the patient on injection isoprenaline infusion. As the patient was febrile, we also started cold saline infusion and also through the Ryle's tube to induce hypothermia. After we started isoprenaline, the patient settled. This was one of the interim ECG taken during the VF storm, where you can see the V1 and V2 showing the pronounced Brugada pattern. These was taken in the higher position of the upper intercostal spaces. So once the VF storm settled, we can note the ST changes in V1 and V2 has significantly come down, but still the Brugada pattern was persisting. As this patient had multiple zoo of VT, VF, and atrial fibrillation and multiple ectopics, particularly this monomorphic VT in the case of Brugada is it's not very common. So we wanted to see any other etiology is existing in this patient. So we did a cardiac MRI for this patient. To our surprise, in the cardiac MRI, we noted there was a scar in the right ventricular free wall and also in the septum. Along with this, there were multiple mediastinal and cervical lymphadenopathy. To see what it is, we did PET for this patient. The PET showed inflammatory myocarditis involving the right ventricle and the left ventricle, along with lot of FDG-avid lymph node in the mediastinum, along with the lung involvement. So we did the lymph node biopsy. The easily accessible node was the supraclavicular node. So we did the left supraclavicular lymph node, which showed a high SUV max. But what we could see was only reactive hyperplasia was seen. There were no granulomas. We did all the investigations for tuberculosis in this patient from the tissue, but there were no evidence for tuberculosis in this patient. As the patient was very socioeconomically from a very weak background, we gave a donated single chamber ICD for this patient. As there was no quinine or quinidine available, so we started the patient on silastazole, which has shown in some studies to have some effect in preventing the VF episodes in Brugada. So we wanted to add one more drug. So we empirically tried theophylline, which has a very similar action, that is phosphodiesterase inhibitor, along with an anti-inflammatory effect. So theophylline has this effect. So we thought this patient, a case of Brugada, who needs a sympathomimetic drug and also anti-inflammatory drug. So let's try this. So we added the empiric theophylline. And as the patient had a myocarditis with lymphadenopathy with negative tubercular investigation, we started the patient on oral steroids. So this was the PET repeated for this patient after a span of 3 months. And what you can note is the inflammation has come down, and all the nodes has been melted away with steroid therapy. So we were very happy that the patient has responded well to the steroid therapy. But what happened after the next month was a patient came with around 16 appropriate ICD shots. So you can see from here the patient was having multiple episodes of ventricular fibrillation. About 1 in 5 minutes he was getting ventricular fibrillation. As it was a donated ICD, the battery life was also getting drained and it was showing only 2 years. We switched off the ICD therapy. So we went into the manual mode. We connected the external patch and we started giving shocks externally. So the patient got around 100 shocks overnight. And so what you see here is we don't want to give high energy shocks. We were also not very sure about the prognosis in this patient. Initially, we gave 200 shocks, high energy shocks. So later we tried on giving a low joule shock also. So what you see here is initially we gave a 49 joule shock and the VF got terminated. Next we tried with the lesser, that is 10 joule shock, but the VF is clearly, there was no termination. It was an unsuccessful. So in between we chose 30 joule shock. So overnight he was receiving more than 130 joule shock. So patient intermittently had atrial fibrillation also, and you can see the patient has developed the fractionation of the QRS, and also there is an ST changes in V1 and V3. So already we know that this patient had responded well to isoprenylin infusion. We started this patient on isoprenylin infusion. We induced hypothermia. We put him on general anesthesia, but none of these therapies were successful this time. So you can see as he got admitted on Saturday. So Sunday morning we were wheeling the patient to the cath lab. So you can see that every minute he was getting a VF and a shock through the device, because we had switched on the device during the transit time. So with this background, we took this patient for ablation. So this was the baseline ECG of the patient in the EP lab. You can see the V1 and V2 showing the elevation pattern of Brugada, and also there is a fractionation of the QRS in the lead V2, which is a high risk feature in the case of Brugada. One of the feature we had observed during the in the cath lab was we saw whenever the VPC comes, this VPC was a RVOT VPC. So the beat that comes next to the VPC had a the repolarization abnormality. So you can see this beat, it's a normal pattern, and this beat is also having a normal pattern. After a VPC occurs, this is an RVOT VPC that has come here. The next beat that comes after a VPC had a repolarization pattern. Again, this pause induced repolarization pattern is a typical of an Ito channel abnormality. Again, proving this is it's a case of Brugada that has gone in for this kind of an abnormality. So we tried to first localize the PVC. We localized the PVC in the RVOT free wall. We got a good unipolar signal here, as you can see from the EGMs displayed here. And along with that, there were a lot of scar area in the endocardium. We did epi-endocardial ablation in this patient. So this was the pace map that you can see. This is the Holter I have displayed. So this is the baseline outflow tract VPC, and these are the pace mapped from the RV endocardium. It was a 12 by 12 pace map of the VPC we could get. So during ablation, in that earliest site, again the patient went in for a degenerated into the VF storm. And these are the abnormal signals. We got low voltage signals, we got delayed signals, and ILPs also we got. And these were the epicardial substrate that we got. These were the low voltage epicardial substrates. So this is two of the carto images are epicardial substrate map showing a lot of scar area, and there were a lot of abnormal signals, delayed potentials, late potentials, and all these areas were ablated. Since the patient was very sick, we did not do any mapping of the ventricle because there was some inflammation initially in the PET showing in the ventricular region also. So this is the cine image. So this is the post ablation ECG. You can see the V1 and V2. It is not showing any pronounced changes as before, but there is a clear fractionation pattern that you can observe in these ECGs. So we also instilled warm saline into the epicardial through the epicardial catheter that we had placed, and there were no dynamic repolarization abnormality after instilling the warm saline in this patient. So this is to compare the pre and post ablation ECGs, where this is the pre-ablation ECG where you can see in V1 and V2 where there is a pronounced ST changes, and post ablation this has really come down. So this is the ECG of that the patient which was taken later, and this ECG pattern persisted throughout his follow-up period. And the patient now presently it's more than it's nearing a year. Patient's steroid has been tapered off, and we are continuing him on theophylline and phosphodiesterase 3 inhibitor. We also gave quinine also, but it's not all the time we are able to get that. We also did genetic analysis. So the genetic analysis did not show any pathogenic mutation, but it showed the variant for SCN5A and CalNAC1 gene, and we showed the genetist opinion, and it's been of no significance. It's undetermined. It's a variant of an undetermined significance. So we have got by now 6 patients with this catheter ablation in Brugada. This is the first patient with the background of an inflammatory cardiomyopathy with Brugada syndrome. So all of these patients are really doing well. And when we looked up what is the role of inflammation in Brugada, we found a couple of papers, and one paper is from published by Dr. Anthony Lee from Dr. Kalyanam Shivakumar group, where they reported a very similar case of inflammatory myocarditis with Brugada VT storm. There also they could not demonstrate a granuloma they could not demonstrate granuloma. What is different in our case also had a mediastinal lymphadenopathy, which goes more in favor of cardiac sarcoidosis. And when we looked at the other literature concerning the inflammation, and there are various biopsy series study in the right ventricular outflow tract which are showing inflammation in the right ventricular outflow tract, and if there is a inflammation, and it is those subsets are more prone for this kind of a malignant presentation. So what we conclude is that there are many possibilities in this case. One, this inflammatory cardiomyopathy and Brugada pattern coexisting, or it is just a chance association. So this is really an interesting arena where what is the role of inflammation in such cases. So the inflammatory cardiomyopathy presenting as Brugada with ECG repolarization abnormalities. So we tried various drugs, and one of the drug is theophylline, and which acts very similar to cilostazol. And what we feel is the Brugada could be a form of an early cardiomyopathy characterized by electrical abnormalities, or a combined ion channel disorder with cardiomyopathy produced by antecedent or persistent inflammation. And the catheter ablation of an abnormal substrate along with VF triggering PVC it really helps in survival of the patient. So this case was we had submitted this case in HRS, and this case was selected for and one among the 26 cases of EP concepts ignited in innovative technologies. Thank you for the opportunity.
Very nice. You need a huge applause for the acceptance of the case in HRS. I think all of us should give him a huge applause for that. Everybody's on mute, so I will just do that for you.
Thank you.
Yeah, excellent case. Very great presentation, Vikram. Really great. Can you hear me, Vikram?
Yes, sir. Thank you, sir.
There are some important questions from the group. I think Dr. Yash wanted to know specifically why a cardiac sympathetic denervation was not considered in this particular case. Any specific?
Sir, in Brugada, we need more of a sympathetic overdrive, so we really did not think that that is an option. And overnight, this patient presented with V of Strom, and if I remember, all our team members were in the India Live conference in Bangalore, and later I was joined by Dr. Daljit. So till that time, I was I managed the patient with whatever I know. So there were no senior members or anyone. So with this patient, I was giving repeated shocks throughout the night with various jewels. I was trying, and I want him to survive. That was the instinct. So I was waiting for Dr. Daljit and Narasimhan to join me. So there was no really lot of time to think and act. So, but sympathetic denervation we did not think, because we need more of a sympathetic activity, like how isoprenaline helps in this patient.
So prenalin doesn't necessarily act through the sympathetic hyperactivity. But anyway, It's also not surprising that an SCN5A mutation was not found in this case. Generally, it happens only in 5 to 25% of the cases.
Yes, sir.
Any other specific questions? Did I miss any question, Dr. Vanita?
Dr. NN, there were a lot of questions on the
There were all comments
chat.
congratulating him. Then all some comments like
somebody was asking about the availability of quinidine. I think that has been answered. I think Dr. Narasimhan has been answering these questions along with it.
Dr. Kantharia has asked one question right now.
Yeah.
Quinidine. It is regarding quinidine. Dr. Narasimhan, sir, would you like to comment on this? Any specific comments you would like to make?
Dr. Bharat has asked a question to the speaker. What would you do when current ICD battery runs out?
We have a stockpile of donated device, and so we've been getting from the patients, well-wishers, and the social workers. So I think we'll be able to.
Yeah, I've been sending them quite a
patient
lot.
Under,
So
patient
that
under
my
and
question, my question was more broad in the sense that, yes, you did ablate the early coupled PVCs, right? But that's not necessarily the end of it, right? So just because there was an acute success, we don't know the pathophysiology of this early coupled PVC, right? Which triggered the event in the first place. In the environment, the substrate which changed. So there is definitely a role to have a defibrillator implantation in spite of a successful ablation. And I think, that's why what my question, when the battery runs out, you just cannot simply say, okay, even it was, I think you probably should. And if you don't find it, just contact me, I'll send you one. But my question was again for quinidine. I think I'm really surprised that, we look from US to India to get quinidine. I have similar patients with early coupled PVCs, young individuals, and I put them on quinidine, and they're very well kind of, no arrhythmias as such. So if you guys don't have quinidine, where am I going to find this? So that was a larger question. So anyway.
I think Dr. Ramdev Yadav has answered that question, that it is synthesized in India, in Goa, but somehow it is not available here. Yeah. And Dr. Namudri, you were asking Dr. Narasimhan. I think I interrupted in between. I'm sorry.
Dr. Narasimhan wants to give, sir, any comment on that?
No, nothing. I don't have. Quinidine is not available. Yash and Nitish Naik have been working on this for quite some time. They couldn't get it.
For many years. Yeah, everyone, even Junaid sir was working on that previously, but there was a major difficulty in getting that.
I will see.
Go on to the next case in that case.
Go. Sure, sir.
And that is by Dr. Muthaya.
Yeah.
Dr. Muthaya, please.
Hey, good evening, everyone. You can see my screen? Hello? You can hear me?
Yes, Dr. Muthaya, we can hear you.
Sound is not good.
Just 1 second. Is the screen seen?
No, not yet.
1 second.
And now your screen is seen.
Better?
Yes.
Okay. Hey, good evening. So I will just be continuing with another case of VT storm in a non-ischemic patient. So this man is 56 years old, dilated phase of hypertrophic cardiomyopathy, EF of 25%. He had an ICD in 2011, paroxysmal AF on anticoagulation. He was in NYHA class 2 from 2012 to 18 on heart failure medications. And he presented with a VT storm and cardiogenic shock in February 2019. So this is just to show the progression of his disease from the time of initial ICD implant to the current time now. So this was his ECG in 2011. which you can see a left branch morphology, but relatively the QRS complex is still narrow. And although there is atrial disease, you can compare it with the ECG in 2018, where you have a broad QRS, IVCD, and significantly more atrial disease, and also possibly an evidence of intra-atrial block also in the inferior leads. So this was the ECG at presentation of VT, and this ECG is left bundle morphology and some likely exit from the inferior septum, but the initial part of the QRS is sharp. And this is the initial ECG before we managed him. And management of this patient initially was with IV Zylocard and IV amiodarone with propranolol. And after he came to the hospital, after 5 days, he was VT free for more than 12 hours. He was maintained on hemodynamic support during this time. And after this, at this point, we took him up for ablation under general anesthesia. So he was taken up for ablation with hemodynamic support. This is the baseline QRS, 182 milliseconds. These are the baseline intervals. And the baseline HV was 61 milliseconds. So on initial mapping in the endocardium, LV endocardium, we found these signals in the LV anteroseptum, fractionated signals that we can see here. And we saw multiple different types of fractionated signals during endocardial mapping. And another similar signal to this fractionated signal, when we paced from the signal here, we saw a decrement. And this was an area of relatively dense scar where the voltage was 0.3 to 0.4. So this may be one of the possible slow conducting areas of this VT circuit. But unfortunately, we could not be, despite this pacing, we were not able to induce a sustained monomorphic VT in this patient, despite presenting initially with the VT storm. And these 3 beats is as much as we got during the initial endocardial mapping and pacing. This was the voltage map and substrate at this point. So you can see the scar is predominantly on the LV and septum and anterior wall. And you can see that the point that is labeled here is this point here, which showed a fractionated signal similar to the one I had seen before. So by the time this ablation had reached this stage, it was already 2 to 3 hours, and he had started developing some hemodynamic instability with more worsening lactic acidosis. At this point in time, we stopped the ablation at this point. And we were not very aggressive with stimulation at this point. We did not try any isoprenaline given his hemodynamic circumstances. But then after ablation, we optimized his heart failure and antiarrhythmic drugs, and he was free of ventricular tachycardia. So at that point, also his ICD, which was nearing ERI at that point in time, and because he continued to be in NYHA class 3 to 4 even after the VT ablation, we upgraded the device to a CRTD. And this is the BIV-paced ECG that you can see here. So after the device was upgraded to CRTD, he remained in NYHA class 2. There were no further VT episodes for the next 1 month. Following this, he presented again 1 month later, again with a VT storm with multiple appropriate shocks and in cardiogenic shock. And this ECG is slightly different than the first VT ECG I showed you. And you can just see here, this is the beginning of the QRS complex in this ECG. And you can see that the initial portion of this QRS is very fragmented and slurred. So our initial impression seeing this ECG was that the substrate was epicardially, or this exit at least was epicardially. And the QS pattern was seen in lead 1 and AVL, which was not seen on the initial ECG. And this is the previous VT ECG that you can see here. So the previous ECG, the initial component is more sharp, and that Q wave is much more pronounced in this current ECG. So this time we planned for a repeat ablation with an epicardial access, and again took him up under general anesthesia. The epicardium was mapped by a duodecapolar catheter with 1 mm spacing. And this is what this was the baseline intervals we recorded. An HV of 68 milliseconds, AH was 135 milliseconds, and this was the signals. This was initial mapping in the epicardium in the LV lateral wall. We can see multiple late signals that we found in the LV lateral wall area, and the majority of his substrate remained in the LV lateral wall of the epicardium and extended also to the posterior wall. So these were the maps that were the epicardial maps that were seen. You can see that the substrate is in the lateral wall and extending into the posterior wall of LV. Just to remind that the first endocardial substrate was more on the anterior and the anteroseptum, and the scar was more extensive in this patient in the epicardium compared to the endocardium. So this is just to show left lateral and the extension of scar from the lateral to posterior walls. This was a late potential map that we created using the end of the QRS as the annotation point, and everything beyond this was in blue and purple were the late areas of activation. So the latest areas of activation here, you can see in the left lateral view, were on the LV lateral wall and extending into the posterior wall in correlation with the areas of denser scar in the epicardium. So after this LV epicardial substrate was ablated, we paced from the endocardium, and when we did a program extra stimulation 500, 350, 310, 300, we found that there was few changes. One, that there were two components to the ventricular EGM, and there was delay between these two components of the fragmented signal as we were giving premature extras. And also, following these premature extras, we initiated a tachycardia started, and the tachycardia started with a H, with a prolongation of the VH interval. And this is the tachycardia that we can see here. Tachycardia was a cycle length of 370 milliseconds, and we can see that a few things. One, that this is a positive HV tachycardia. The HV interval is 98 milliseconds, which is longer than the HV in sinus rhythm, which was 63 milliseconds. In addition, what we can see here is it's the HH changes in cycle length are driving the VV changes in the cycle. There is also evidence of VA dissociation during the tachycardia, and on the right you can see the 12-lead morphology of the VT. And the VT cycle length was approximately 230 milliseconds, and I'll come back to that. VT cycle length was 370 milliseconds. And you can also see that the His activation, you can see the His proximal, His mid, and His distal. The activation of the His was from proximal to distal during tachycardia. So this was a very extremely hemodynamically unstable VT, and every time that the VT was induced, we had to cardio with this patient. So we could not entrain or do any activation mapping in this patient during the tachycardia. So what are the possibilities? This is a wide complex tachycardia, left bundle branch block, right axis deviation. It's a positive HV interval, and the HV in tachy is more than the HV in sinus rhythm. So we made diagnosis of a bundle branch re-entry VT. So the hemodynamics prevented us from doing an activation or pace mapping in this patient. So we tried other methods to support our diagnosis of a bundle branch re-entry VT. So in retrospect, when we looked up his ICD data, you can see that his ICD lead is in the RV apex. And you can see that during his VT, when we have an ATP episode, the ATP is entraining the tachycardia. We are not sure about whether it's concealed or manifest because the output during ATP is significantly higher and masks the morphology of the far field signals. But you can see the post-pacing interval minus tachycardia cycle length was 20 milliseconds from the RV lead. So maybe this is supporting evidence of a short PPI TCL from the RV apex. This was the ECGs during sinus rhythm and during VT. And you can see that during the sinus rhythm and the VT ECGs, you can see that the QRS complexes are similar, except that the QRS duration and the VT duration, the VT was long, the QRS duration was longer during VT compared to sinus rhythm. The second point is looking at the His bundle activation. So in sinus rhythm, the His bundle is being activated from proximal to distal, as well as in VT, the His bundle is being activated from proximal to distal. So the His bundle activation was similar during sinus rhythm and during ventricular tachycardia, and except that the HV was longer during tachycardia compared to sinus rhythm. So what does this mean? So this means that there has to be antegrade conduction down the right bundle in order to have both proximal to distal during sinus and VT. So the likely circuit was retrograde up the left bundle, antegrade down the right bundle, completing the circuit of possibly a counterclockwise bundle branch reentry VT. So we ablated the distal right bundle, and there was no further VT inducible with similar stimulation protocols after the first ablation, and he's doing well with 1 year of follow-up. So this is just to show that we had another patient maybe 4 weeks later, and this patient also a 32-year-old with HOCM with this time a preserved ejection fraction. But this patient also, we found that the predominant substrate was in the epicardium for this patient with less substrate in the endocardium. So this is just to show that in the substrate in hypertrophic cardiomyopathy can be different in the endocardium and epicardium. And till now, in the 8 patients with HCM who have undergone VT ablation at our center, 3 have had a bundle branch re-entry. And although it's uncommon, it can be a rare cause of VT in non-ischemic cardiomyopathy. Thank you.
Hello.
Hello, sir.
Hello.
Yes, I can hear you, sir.
Yeah. Very good presentation, Dr. Muthaiya. There is one question from the group. Why was the axis right? Why was there an axis, a right axis deviation during the VT? This was asked by.
So there is a significant myocardial disease in this patient, sir. And if you saw the initial, I can just show you if I go back.
Yeah.
So you can see that the baseline ECG itself tends towards a right axis deviation. So this is probably a part of the myocardial disease in this patient that has led to this right axis deviation that continued during the VT.
Did he have an outflow gradient to begin with in the history?
No, sir. This was a non-obstructive HCM that thereafter developed a dilated phase of the disease.
Because most of the cases we see in the dilated phase of hypertrophic cardiomyopathy, they had mid-cavity obstruction. I don't know whether this was observed by others as well. And even in the largest series from Japan, where they have noted some 4 to 5% of this hypertrophic cardiomyopathy developing, many of them had mid-cavity obstruction. But once they go into dilated phase, the management becomes extremely difficult with a VT storm, heart failure, and they do much worse in that phase.
So most of the patients in our center, most ended up in a dilated phase before they developed the VT. There were 1 or 2 patients who developed an apical aneurysm, most likely due to this mid-cavity gradient.
Obstruction. Yeah, that is exactly what we have also observed. Some of them had, and some of them were diagnosed initially as post myocardial infarction, LV apical aneurysm and all. And then when we looked into the previous, cath data and other details or family history, we could make the correct diagnosis. This is often a misunderstood or rarely diagnosed entity. Many times it is diagnosed as apical aneurysm in a post-MI case.
Yes, sir.
There are some questions in case you please.
Yeah. Question 2, I might have missed, but late potential map were beyond the conventional bundle branch. Dr. Narasimhan can answer the question. This is by Dr. Bharat Kandaria. Dr. Bharat, you'd like to, would you like to explain that question?
Let me ask. I think I just unmuted.
Yeah.
So I think I might have missed the whole map, the late potentials, and I'm not sure that you guys did lava both on the epicardium and the endocardium. But if you go back and show me, I think if you just think of a conventional bundle branch reentrant VT, that's most of the scars should be in that area, and by ablating just the right bundle, you still have the others probably primary or secondary circuits still active.
Yes,
so I'm a little bit kind of confused here that there's some amount of disconnect that yes, you did induce bundle branch reentrant VT, which can be a non, maybe just a bystander in a sense that so many patients with cardiomyopathy can have
Dr. Bharat.
Yeah.
Can you hear me? When we have a structural heart disease, we always try to understand about this. I think your concerns are right. And it is not that we are trying to sort of cure a problem of VT, except, the idiopathic VTs. But we are trying to understand the underlying structural heart disease. So I think you're perfectly right. And Nambudri is also right. And I'm sure that the EIG team has got great experience, which we do not have, where they have been doing this, ablations. And that's fine. We have to accept very scientific points, isn't it? Hello?
You're asking me?
Sir.
Yeah.
And at the end of the day, we need to look at what the patients, how many patients we are going to treat with ablation. Correct?
Yes, sir.
And does every patient have sarcoidosis or granulomatous disease? We are passing on a message to youngsters about how to detect things. And not everybody has this issues about MRI and 3D mapping. So when are we going to sort of supply this information for younger EPs to identify patients who should be referred to a higher center like AIG hospitals, or be done by themselves, is something which we should concern ourselves, isn't it? I'm growing old, I feel much more older than Narasimhan. So I'm trying to pass on a message with this thing. I may be wrong. We can do something. Every one of us can do something, including the youngers. But nevertheless, how should we identify something which is a myocarditis, which is something different than a cardiomyopathy? Who is going to go to a very high center like AIG hospital versus somebody who is going to be done in a simple center? Is some message probably we should discuss about this. Wouldn't you think so? I mean, you have done a fantastic job. I'm not even questioning that. Correct? Hello? I see Narasimhan. No, Narayan there. I don't know. He's smiling whimsically. I don't know. But nevertheless, that's my view. I may be wrong. Please. So for me, it depends on various things. We can do some fantastic things. I think we also have to look at when we are doing these things to pass on some message.
Yeah.
So people who are unable to do something, whom should we recognize? Who's got a atrial cardiomyopathy or a ventricular cardiomyopathy versus a myocarditis, and who should be sent to a center which should be doing very high quality cases like AG and Sri Chitra. I don't know. I'm still struggling with that.
Yeah. What was the HV interval after the ablation of right bundle? I mean, in this case, was
no, you know, Narasimhan.
Narayanan, sir.
Narayan, sorry. So, Narayan, oh yes, I can't see you. I'm growing old, man. I'm trying to put my specs back.
There is a comment from Dr. Narasimhan which has been written here.
Should we address that?
Address it, please. Narasimhan is a very senior person. We should address it because he's going to direct.
Yeah, he has written clearly that late potentials were ablated in the epicardium as it is part of the disease. And later Bundy branch re-entry was induced. This patient had, sir. Yeah, just let me, this patient had a VT storm from endo-epicardial aspect and had Bundy branch re-entry and VT also. So of course that is true because the electrogram, device electrogram also showed a very short post-spacing interval.
No, that's okay. But what is the definition of a VT storm? What is a incessant VT? Have we discussed about it? No. VT storm is when you have more than 3 episodes, right? In 24 hours. Correct? And incessant VT is different. Recurrent VT is different. Narayan.
Yes, sir. Yeah.
So I think we should discuss all these aspects. So nevertheless, it's a great case.
Yeah.
And for me, I'm very specific. Doesn't matter what I am, where I am. And I think you're busy and you're run out of time. Another 5 minutes. So we have to define between recurrent VT. We have to define about a VT storm. We have to define about an incessant VT. We have to define things about whether it is myocarditis, whether it is cardiomyopathies. So we can't do this, my friend, please. It is, I'm sorry to say that it is not acceptable to me. You may find me wrong, please. According to the definition, I find not acceptable, please, but I think it's a great case.
Any specific questions from the group? I think we have already discussed.
I'll tell you what. I'll ask people if they want, they can, you can look at, atrial myopathies, which has been already described by Zipes very long back, 1997, but it's also been described by Cheras, please. And all of you can look at what is myocarditis and cardiomyopathies. Great case.
I think Dr. Namudri and Dr. JP, if there are no more comments, we can close the meeting. Yeah. With your permission, I'm just going to close the meeting.
Okay. Wonderful.
And I just for the reminder to everybody, now our meetings will be on Friday at 7 p.m. Every Friday, 7 p.m. That's it. And thank you so much for all the